All right. Well, good afternoon, everyone. My name is Leopoldo Cavazza, and along with Dr. Byron Powell, we're the co-director of the Center for Mental Health Services Research. And welcome to our last session of our monthly seminar. We're very excited today to have Dr. Adrian Aguilera from UC Berkeley. Dr. Aguilera is an associate professor from the School of Social Welfare at UC Berkeley and the Department of Psychiatry at USC San Francisco. He received his BA from Stanford University and his Ph.D. in clinical psychology from UCLA. At UC Berkeley, Dr. Aguilera directs the Digital Health Equity and Access Lab and the Latinx Center of Excellence. And at UCSF, he directs the Latin Mental Health Research Program. Dr. Aguilera's research is focused on developing and testing technology-based interventions to address health disparities in low-income and vulnerable population. His work has focused on utilizing mobile phone technology to disseminate mental health interventions, and his interventions are primarily focused on using text messaging, which has been applied to three very exciting areas: as an adjunct of cognitive behavioral treatment, as a public health mental health intervention for COVID-19 related stresses and anxiety, and using machine learning-based intervention to personalize messages to motivate physical activity for individuals with diabetes and depression. So we're very excited to have him today present a digital health intervention for depression and diabetes in underserved population. And today's talk is actually also being co-sponsored by the Center for the Study of Race, Ethnicity, and Equity, CRE2, from Washington University. So we're very excited to have this new collaboration within our center. So Dr. Aguilera, it's great to see you, and please take it away. You can share your slides when you're ready.
Great, thank you so much for having me. And thank you all for attending. Just want to start by setting the stage in terms of questions. Feel free to chime in as things go along. I'll keep the chat window open if you want to post something in there as well. We can keep things, it's a relatively small group, so we can keep things somewhat informal as well. So today I'm going to give you an overview of some of those projects that Dr. Cavazza mentioned, with a focus primarily on depression, but then lately also bringing in some issues related to diabetes interventions as well. So the basis for a lot of this work is really founded upon the proliferation of mobile phones. And we know globally there are over 5 billion people own mobile phones. I believe the number of smartphones is 3-point-something billion and increasing. So these phones have provided us with the opportunity to connect with people in their daily lives and to essentially make easier the sending and receiving of information that we hope to leverage for improving health. When we think about digital health, it's quite broad and in some ways getting broader every day as new technologies are introduced. But this is the general landscape of digital health. Most of what I tend to focus on is the areas of text messaging, a little bit of consumer mobile apps, but as you can see, there's a variety of what is digital health. Another thing that I like to present is kind of an overview to provide a context around digital health. Digital health has been kind of a victim of a lot of hype, as are many new things that come on board and new technologies. And so there's this digital health hype cycle that gives us a visual for how technologies kind of start out as triggers, and then soon after there's a lot of expectation. Usually it's exaggerated, right? So this is a graph from 2017 where AI and machine learning was going to solve everything. And then there's other things around that time. We all remember Google Glass and the big epic failure of Google Glass, right? That moves into what's called the trough of disillusionment. And then other technologies, as they move on, start to move on to, ideally what's called the plateau of productivity. And I present this because I think it's important to take these things into context in terms of ideally not getting overly excited and not getting overly disappointed, but instead to find where we can apply these technologies. So it's not technology for technology's sake, but technology for the service of solving problems. And here we see one from 2018 where some things have kind of moved along. We see that telehealth is now over here, which we know that to be the case absolutely now. You know, machine learning has kind of moved on a little bit after maybe having some disappointment. And then, you know, another example of machine learning kind of now being in the productivity realm. So again, just something to keep in mind as new technologies come on board and keeping them into perspective. When we look at digital health apps broadly, what we see is that the plurality of applications target mental health and behavioral disorders, right? And then another big chunk target diabetes, so those two together make up almost half of applications, some others in the kind of the heart circulatory system. And one of the reasons for this is that all of these have in common the behavioral nature of the health conditions, the chronic nature of the health conditions, and therefore the ability to use something like a smartphone to improve self-management. When we look at the broad kind of mental health landscape from the private sector, we could see, you know, one big takeaway is that there's a lot of money out there, right? A second takeaway is that that money is only growing. These figures are, I believe, before the pandemic. And so the numbers that's being poured into these companies is growing rapidly. But you'll notice some of these names here, and they kind of, this graphic does a good job of putting things into some categories. They're not perfect, but gives us an idea that there's some applications that are in what we might call computerized CBT of some sort, so a different way to deliver CBT. There's telepsychiatry, more provider-based tools, so these are things that providers won't see, just consumer tools. Hardware, these are things we hear less about, but these would be things like, you know, biofeedback headsets or something along those lines. And then there's some applied AI. One probably more popular example is Wobot, which is a chatbot intervention for mental health problems. So just to give you an overview of kind of where at least the private sector is targeting these things. And I think it's helpful. If you look at digital health broadly, particularly in the private sector, we see that a lot of the targets of these types of tools tend to be people that are already healthy. So the target is to optimize health rather than to achieve health. Right? And so these are different kind of goals that often happen. Obviously, the goal of these products is a capitalistic goal of making money versus necessarily solving a problem, right? But it's still some as we start to use these things, we have to realize where the goals might be different, and that may be one of the reasons why the needs of helping people who don't have a certain level of mental health or health are not being achieved. When we think about access, language is a big issue. So the huge majority of digital health apps are available in English. And then the next, so over 200,000 apps in English. And then you have over 40,000 in Chinese, German, Spanish, French. So big difference in terms of what's available based on the language that people speak. And these other languages, when we think about things globally, are even less, right? So who is accessing these resources? Also, when we look at it's kind of related to the graphic of who is being targeted. When we look at the top funded digital health companies and who they are studying, it's mostly healthy volunteers. Not enrolling high burden populations, not addressing the outcomes of cost or access to care. And these are some of the key factors of why the promise of digital health is not actually reducing disease burden or cost at the system level, right? Because that's not what they're aiming to do, frankly. They're aiming to maybe sell products, not specifically targeting reductions in disease burden, for example. So, you know, when we think about mental health and digital disparities, they kind of come together, and that's kind of the area that I tend to work in primarily. We know that racial and ethnic minorities are less likely to receive mental health care when needed, and when they do, they receive lower quality of care, right? That's kind of the basis. I think a lot of us know that. Patients from diverse backgrounds, when given digital tools, particularly folks that have low levels of education, have difficulty completing core functions of many commercially available applications, doing things such as tracking mood, inputting glucose values, etc. And really our concern is that if marginalized and underserved populations aren't considered in the development and evaluation of digital mental health tools, these technologies might serve to further entrench rather than overcome existing disparities. Right? So that's always at the forefront of the way I'm thinking about the intersection between technology and mental health interventions in particular. So when we look at, we hear a lot about the digital divide, and indeed there are some digital disparities. They're not they're not straightforward. Folks from Latinx backgrounds are more likely to be smartphone dependent compared to whites, and they're more likely to interact via text messaging or platforms such as WhatsApp. And although access is variable, a large majority of Latinx primary care patients stated in this study that they were interested in utilizing a health app, and some even said they would use such a thing daily. These are so there is some desire, there's some possibility there, right? And then thinking broadly, an impediment of the impact of these interventions is that inclusion of diverse groups such as African Americans, for example, is very low in mobile health intervention studies, therefore making the results of such interventions or studies of interventions not necessarily applicable to all, right? Or at the very least, not, unclear at the very least, ineffective at the worst. This is an overview of technology-based adoption. And what we see here is that there's significant differences in accessibility or ownership of desktops and laptops, and then also in home broadband use. So these are relevant when we think about the types of interventions, how we develop our interventions, and the data intensivity of interventions. So if you don't have home broadband, if you have let's say a prepaid data plan, there are considerations around, even if you develop such interventions, of not making people go over their data caps, for example, right? So keeping those things in mind. Even though smartphone ownership rates are relatively similar across groups. Okay. Recently, this is now a couple of years back, the National Academies of Sciences and Engineering and Medicine put together a digital health equity workshop. And really, I found it interesting that the main point gleaned from this workshop is that technology is really about people, right? And addressing disparities and increasing equity goes back to the foundation of placing people first and not technology first. And I think there's a core element as to why we've had limited success broadly in applying these technologies, because we get kind of similar to the digital health hype cycle graph that I presented earlier, is there's this hype around the technology, and we tend to forget the people, the people that technology is supposed to be serving. So similar to research addressing disparities broadly, we have to integrate community engagement in the design, evaluation, and adaptation of technology-based interventions. Right? Okay, so so that's kind of gives you the overview of the field in a sense. So just want to check in to see what questions you might have before jumping into kind of some of the details of some of the studies I've done.
And if people want to put stuff in the chat, we'll put your questions in the chat, or not, or mute yourselves and ask any questions.
Okay. So now I want to, I'm going to talk to you a little bit more specifically about my work integrating technology into CBT for depression in the public sector in a safety net clinic. And really the motivation for all this, which I think it's important to center the motivation when we think about technology-based interventions, because they should be addressing a problem and not be applied just because it's cool and new and fancy, right? And so the problem that we've tried to address, okay, before I go, sorry, smartphone dependent. That's a great question, Jackie. Smartphone dependent means that that internet is only accessed through smartphones and no other means. So, you know, these are folks who don't use a computer to access the internet. And so as we all know, the experience of accessing the internet looks very different when you're doing it via phone versus when you're doing it on a computer. So when we look at CBT for depression in the public sector and safety net clinics, we know that attendance predicts improvement. But we know that there's high dropout rates, low homework completion rates, right? And so these are key problems in terms of getting an adequate dosage of this behavioral intervention to people who need it. This is a graph of naturalistic group attendance to the CBT groups that we ran in the primary care clinics before our texting intervention. And it's a 16-week treatment. So in theory, this number would be really high, and then all the other bars would be really low. Well, we all know in reality that's not the way things work. And we know that in mental health services, there's high levels of attrition, right? So most people only attend 2, 3, 4 sessions, right? Out of 16. So that's a problem. If we know that an intervention works, and it has been studied in this population, but they don't get the actual treatment, it's not going to have the effect, right? That's relatively straightforward. So how can we get more of that treatment to more people? And we know that this issue of attrition is broad in terms of psychotherapy interventions in particular, higher for low-income and ethnic minority patients, and also high for technology-based interventions, particularly when they don't have a human support element. So the goal is to leverage text messaging to improve treatment quality and engagement. How did we do this and why? Because they're widely accessible, cost efficient, they don't take up data. People read their texts, people generally respond to text by and large, right? Some studies, it's hard to measure this, but some studies say that people read up to 98% of their messages, right? And I think at least there may be some variability, but I think from personal experience, I think we all have a sense of, you know, the sticky nature of text messaging. It is a good way to get somebody's attention at least. There's also a greater sense of personal connection, right? It's messages come through a messaging app that we use already and we use for other forms of connection. And so it has that connotation to it. So the intervention was run as a group intervention weekly for 16 weeks of 4 modules of 4 weeks each, with rolling admission beginning at the starting with people coming in at the beginning of each module. For the RCT that we ran, they were all Spanish speakers, and we weren't able to fully randomize because we had to keep groups balanced, and we also had to allow for some preferences in terms of time since we couldn't run the groups at the same time. So this is an overview of the sample. And some key takeaways are off on the right. So the average age is 52, not necessarily the typical age of your hypertexter necessarily, right? But we were able to teach folks to use texting if they weren't that familiar. And sure enough, 74% had used text messaging before. So the other 25% or so, we taught them to do it. Another key element to think about is that 68% of our sample had less than a high school education. And so as much as we need to pay attention to cultural differences, a key element of disparities between groups in the US at least is socioeconomic status, and one of the main factors being low levels of education, right? And this also intersects with what we call digital literacy, the ability to interact with digital tools, digital communications, etc. Right? So the way that homework has been done in the past with the CBT intervention we're using this is the base level of homework. So just tracking your mood over the past week, and then tracking something else that's of interest for that week. So maybe it's thoughts, or maybe it's activities, or it's social interactions, for example. And this is what I had reported on before, that only about 23% of people completed this. And that number is high because it's only 23% of the people who attended session, right? So you can imagine people who didn't attend session are probably even less likely to have completed this. So we turned that into a text messaging intervention where we had mood monitoring text messages that were kind of replaced this. We had a theme-based text message, which was meant to replace this element. We also had medication reminders and group attendance reminders. Okay. So the mood monitoring text messages looked like this. They were sent out randomly between 8 a.m. to 9 p.m. Participants responded, and then we gave feedback on a variable ratio schedule in order to increase responses. So using kind of some of our Psych 1 knowledge of different learning paradigms, and we wanted to apply this similar to what you would get when you're using a slot machine, right? You get feedback every so often, and so it provides more motivation to continue engaging. So an example of this is if somebody writes a high mood of 8, it looks like you're feeling good. Think about what you're doing or thinking to keep your mood high, right? So continuously reinforcing the themes of the intervention. These are examples of theme-based text messages that were sent out at the end of the day. So they reinforce whether we were talking about cognitive restructuring, let's say, or behavioral activation, or interpersonal communication. Simple medication reminders that were broad and optional. Group reminders, so to remind people the day before, to ask them if they're coming to session. It also indicates the clinician, just get a sense of whether or not someone's coming. Then once the data gets uploaded to the system, it gets graphed, and then we use it in the intervention. And so here's an example. If we look at the pink line of a participant that wrote on Tuesday, their mood was a 6. So, better than meh, but not that high. And reported, estoy en casa, I'm at home. Whereas the following day reported a mood of 8, so a very high mood, estoy con una amiga, I'm with a friend. And there we could then zoom in to identify, let's say we're talking about thoughts. We can ask what thoughts were going on when you're at home, presumably by yourself, versus when you're with a friend. We can talk about activities, right? What were you doing when you were at home? What were you doing when you're with your friend? Interpersonal elements as well, social support, etc. So this really provides a lot of fodder for teaching the model and the core elements of the intervention. We also can track PHQ-9 over time to just get a sense of how people are doing. And then we also created a dashboard to track how many sessions people attended, figure out when they needed to graduate, etc. And the key finding was related to engagement, that people who texted attended over twice as many sessions. So attended 6 sessions versus 2.5 sessions, right? So also over twice as many. And even more dramatically, the people in the texting condition didn't drop out completely until about 13.5 weeks compared to 3 weeks. And this is a key finding, I think, when we think about the role of technology in keeping people engaged, because what we see is that when people drop out or stop coming for a couple weeks, let's say, they don't come back. Whereas when they're receiving text messages, maybe they stop coming for a bit, but they keep getting text messages and they keep getting text messages, and maybe they get remotivated, right? We know that depression is a disorder of motivation, and it waxes and wanes greatly. If they get to points where they're a little bit more motivated, that text message can serve as a nudge to re-engage in treatment. Text messaging adjuncts can decrease treatment attrition, which can hopefully result in helping more people get better. We did look at clinical differences between the groups, and unfortunately, because of the high level of dropout, we weren't able to follow people up successfully. So there were some small differences, but they were not statistically significant. Once we had this data, we also wanted to see how can we use it to predict important outcomes. So in the case of predicting whether or not someone's going to attend session, we found that mood ratings the day before session predicted whether or not someone's going to show up to session, such that every increase in mood beyond individual's average resulted in a 32% higher likelihood of attending, right? Or vice versa, 32% lower chance of attending with lower mood. Why is this important? Well, we can then identify critical points for micro-interventions, right? So we can outreach to patients in low mood before the therapy session. We can target low mood or talk about the importance of attendance. This can be an automated outreach, or even a clinician calling somebody by phone or knocking on their door, whatever the intervention is, right? But it provides us actionable data. We also looked at whether the mood ratings that we were collecting on a daily basis related to PHQ-9 ratings. Our PHQ-9 is the clinical standard for depression. And indeed, there is a significant relationship between the average of one's weekly mood ratings and PHQ-9 ratings as well. Why is this important? Well, if this relationship is stable, then that means we may be able to use simple mood ratings via mobile phone to assess symptoms amongst large numbers of people, which can then inform monitoring for prevention, for treatment, etc. Right? Particularly in this era of depression screening in primary care, this could serve as an important tool. We also were able to dig a little bit deeper to find out what kinds of users are there. Were there clusters of users, right? Was everybody the same versus everybody different? And the elements that we wanted to specifically look at, sticking along the theme of engagement, is engagement in the live sessions and engagement in the text messages. And what we see is that age is a factor in looking at whether or not somebody is responding to the messages, and PHQ-9 ratings are related to whether or not folks are attending sessions or not. Right? So people who have the groups that have the lowest PHQ-9 at baseline are attending more sessions, and the highest age groups, so 3, for example, have the lowest response rates to text messages. And so it's kind of repeated there again. And this is helpful when we start thinking about targeting, right? Who are the interventions going to be best used for? And also understanding the context of the use. So a lot of patients, for example, told us, I don't respond to the messages, but I read every single one of them, right? So there's different use by different people. And then lastly, in providing, we asked people, this was actually done before we developed and tested the randomized trial, but we asked people in a pilot study how these messages were helpful. And English speakers mentioned to us that they aided in self-reflection, right? Allowed me to look in the proverbial mirror, one patient said. I think the last one is really helpful to understand the context, in particular in thinking about a safety net setting. Sometimes I'm so busy I hardly stop and think about how I feel. Now that I'm getting texts, I stop and think every day. When it stopped, I missed it. My life is so crazy, I need a reminder to think about how I feel, right? And this actually was a natural experiment because there was a bug in the system and it stopped for a week or two. And it allowed for a reflection around kind of what role it has. So these are all things, self-reflection is something we typically encourage patients to engage in, right? To think about how I feel. We asked Spanish speakers the same question. And what we see is a little bit of different themes arising. Folks are mentioning that they feel cared for and supported. I realize that someone cares for me and I'm not alone. They make me feel that people care about my health. So you notice the relational nature of these responses versus the self-reflected, internally focused responses of the English speakers. And while we weren't, at this stage, we weren't looking for this, it makes complete sense when we look at what we understand about cultural differences, particularly psychologically between more individualistic cultures and more relational collectivist cultures. And so the importance of this is to understand, a few things. One is that the interventions that we developed, even if they look exactly the same on paper, are received differently, right? And they are qualitatively different for depending on what the individual is bringing to the table. And this also helps us to think about how can we further personalize interventions to take these things into account. Sometimes I'm asked about suicidality and how that's addressed. And we do instruct patients that this is not direct communication, but patients still feel a connection. There are keywords that trigger a message to a clinician. So if one of these messages is triggered, I'd get a message and can go in and look at what was sent. So here are the lessons learned so far from the mood text work. Patients who text attend more and stay longer. Prior day mood rating predicts attendance. Mood ratings via text can approximate PHQ-9. And there are different types of users, right, based on age and baseline PHQ-9. And overall, patients report interacting with automated text messages. A recent extension of this, last year when the pandemic started, some colleagues and I got together and developed an intervention that was focused on dealing with mental health in the context of social distancing and sheltering in place, particularly early on in the pandemic. So we all developed a 60-day CBT texting program that took some of the content from the mood text program and added some new content where 2 messages were sent per day with various kind of CBT tips. These are some examples. The intervention was available in both Spanish and English, and actually is still available. Although in some ways it's becoming a little bit less relevant depending on the context of some of the messages that are related specifically to social distancing. And what we found is that in a sample that was primarily recruited via social media, PHQ 8 scores, so not the suicide item, reduced by almost 2 points over 60 days. And GAD-2, so it's a 2-item anxiety scale, also significantly decreased over time. These aren't huge changes necessarily. They're small, but it's a very scalable approach, right? Just sending messages out to people broadly with minimal needs on the parts of human support. So this goes back to thinking about the different types of interventions, right? We saw with the mood text be following kind of the type 2 intervention where it's mostly live in person with some technology, whereas this is one that's, you know, all technology, kind of self-management. The impacts are not going to be as great, but the scale is much larger, right? We were able to reach 193 people here, and the other one was a randomized trial of 90 people over, recruited over years, and this was recruited over months. So lastly, I'm going to tell you about a study that's in progress, the Diamante study. And the motivation for this study is that interventions for depression and diabetes tend to be highly siloed, right? One is addressed in mental health, one is addressed in primary care. But physical activity is a core mechanism. If we think about physical activity for depression, we can think about it as behavioral activation, right? Becoming more involved in life, increasing pleasant activities. For diabetes, it's physical activity to improve physical health, processing of glucose, lowering weight, etc. Right? However, mobile health interventions need to be more personalized. They need to be integrated into care, and they need to be developed with vulnerable and underserved populations, right? So again, targeting both of these chronic illnesses with the focus on increased physical activity. And when I talk about vulnerable populations, what I'm referring to are folks with low incomes, low health literacy, and most often people from ethnic minority backgrounds, right? And these are the people that experience the highest prevalence and worst outcomes for both diabetes and depression. But digital health interventions don't start with focusing on these populations usually. If lucky, interventions get trickled down, if you will, and then adapted. Personalization is extremely important because we want to increase the impact, right? And most mobile apps are not personalized. There's some minor personalizations. There's some efforts to do group level or even cultural adaptations, which are important, but even these do not account for individual differences, right? So based on a pilot study from a colleague that used reinforcement learning, we wanted to apply this approach in order to predict and apply the most effective content in physical activity intervention. So we want to increase physical activity by sensing, passive sensing of steps via smartphone, using an algorithm that targets specific motivators for individuals. So this is a little flow of what the intervention looks like. So we count steps via smartphone. That data then gets fed back to an algorithm that decides a message related to one's physical activity, some feedback, and then a motivating message. This is the Diamante app. That's basically a step tracking app and a way to collect step data. These are what some of the messages look like. So I mentioned reinforcement learning, and so just to give you a quick overview of what it is. So reinforcement learning is a type of machine learning. And the goal of reinforcement learning is how software agents, in this case, kind of, a computer takes actions to maximize the cumulative reward, right? And it's a lot of words for basically saying it's trying to make decisions that give you the best outcome that you're looking at. In our case, what we think about when we say reward is steps, and I'll say a little bit more in a bit. So I'm going to get in the weeds so you can kind of understand how this works. So here's some of the terms that I'm going to be using. Action variables are what the algorithm's doing. Contextual variables are what's information about the participant and their surroundings. Reward, so I mentioned reward previously, refers to outcome. In this case, it's steps. And then the model is how we predict what the reward is going to be as a function of these variables. Okay. So the action variables that we're using are feedback messages. So it can send any one of these 4 options, right? No feedback, a message about reaching a goal, steps, walked more or less than your goal. And then we send a motivational message, which could be, one of these 4 options. And within each of these categories, there's a list of messages that can be randomly pulled from there. We developed this using the COM-B model of behavior change, which is kind of a little bit of an amalgamation of different behavior change theories that are focused on increasing capability, opportunity, and motivation to engage in a certain behavior. And then a third action variable, kind of what we personalize on, is sending messages at a certain time of the day, because for certain people, getting a message in the morning might be more effective than getting it in the evening, for example. These are our contextual variables. So we have information about the number of steps you've taken, your demographics, how many days since you've received certain messages, etc. And it all gets put together. And this is an overview. So every morning, the algorithm gets retrained on data of all participants. There's action that's taken by the algorithm based on the action variables that I mentioned. It takes into account the contextual variables. So even things like the weather, for example. So if it's raining, there's going to be some expectation around whether there's going to be a certain number of steps or not. And there's a calculation of what is the reward. The reward here is steps yesterday minus steps the day before. And it makes a calculation based on the different options, and then it'll pull a message from a given category. Importantly, actions that are predicted not to be the best are still going to be tested over time. So this is a Boltzmann or Thompson sampling, is what it's called. And therefore, it's not just about the best message, but sometimes it's about the best sequence of messages. So perhaps it's a benefit message, preceded by no message, for example, right? Because if you can imagine, even if a message is effective, if you send it every day, the effectiveness is going to wane over time. So in summary, we retrain 3 different algorithms every morning, evaluate the reward. The algorithm learns over time what sequences of messages are most effective based on previous observations and the current state. So this work is in progress. We're currently recruiting still, but we think there are a lot of important things to learn from this study to assess what is the impact of algorithmic personalization, right? And developing this from the ground up in a resource-constrained environment, right, with underserved patients, as opposed to relying on this kind of trickle-down digital health, if you will, which I'm generally not a fan of. And if we go from the ground up, results are more likely to be relevant more broadly than the other way around, right? So I'd like to acknowledge funders and just all the people that have helped make this work possible. And thank you very much for staying awake to this point.
Oh, that was
But
great.
now I think we have, yeah, about what, 10 minutes for questions?
Yeah, we have about 10 minutes for questions. This is great. Thank you so much for sharing that, Adrian. I have a question. I was fascinated by this finding of how like people view text messages differently. You talked about that sort of the internal motivation and the external motivation, even with a text message being generated by an algorithm. So that's really interesting to the point of personalization. Not only how can we send messages to people for motivation, but how people actually view them and what's helpful for them. That to me is really getting into the different pieces of that. And so can you speak a little bit more about that? Yeah.
Yeah, and I think that the when we found that, I think is one of the ways that we started realizing how important personalization is, right? That people are motivated by different things and that they respond to different things. So our Spanish-speaking patients, we'd ask them, why do you want to feel better? Why do you want to be healthy? And a lot of times people would say it's because of my family. I want to be there for my family. I want to be a good example, what have you. And for other folks, it's different motivations, right? For other people, it's self-improvement or, achieving certain goals. And it's not to say that one is better than the other. It's just to acknowledge that there are differences, right? And if we recognize that there are differences, then we could, presumably be way better about how we go about personalizing these things. And I think, ultimately a lot of what we do when we're doing interventions, mental health interventions, psychotherapeutic type of interventions, is a lot of this personalization on the fly, right? We do this. But when we build something, when we program something and just send it out, it's a lot harder to do that, right? We're still more, this computer is still more powerful than, the computer that we use on a daily basis. And so, you're never going to equate it, but how can you, change things a bit so that you can rely more on that personalization?
Oh, for sure. So other questions from people. You can put it in the chat or unmute yourselves and discuss.
Hello, I'm Michael Park. I'm a postdoc here. Thank you so much, first of all, sharing this very interesting study. So looking at for example, the responses of the study participants about how they feel about the messages, such as making them stop and think about their own feelings, which almost sounds like mindfulness practice.
Yep.
Do you think the elements of sending text messages itself have positive implications on the outcomes? Because some intervention studies show that when comparing with the comparison group, which only has the elements of text messages, the interventions didn't do better than the comparison group. Mm-hmm. So do you think there is an intervention effect between interventions and text messages, for example? So by meaning that maybe the text message and the physical activities, for example, could together make the intervention more effective? Or do you think, as the later part, you show the intervention studies only with the text messages? So do you think it has to go together with the actual interventions like physical activities, or do you think this personalized text message based interventions is the way to go? Because it sounds very cost effective and very efficient in a certain way, because you're monitoring their personal behaviors, but also their contextual factors.
Right. Yeah, so I think, in short, yes to all of that, right? But more long-winded answer is that kind of by definition, the messages that we send asking people about their mood does a lot of things, right? It's an intervention. So it's a mini mindfulness intervention to some extent, right? So how am I doing? It also is a EMA or ecological momentary assessment, right? To send us data. We can also track kind of progress over time. We can use that data in the intervention. So it serves a lot of different purposes, right? And there is value in sending the messages. I think that some people will respond to messages and it will help them. I think ultimately where we're going with all of this stuff is what works for whom, how much do different individuals need in terms of technology, right? Some people will respond to the technology. Some people probably need technology and a little bit of support, right? Some people need more support, maybe with the technology, and some people are going to need intensive, one-on-one intervention, right? Kind of like going back to that taxonomy. So it's a matter of need to some extent versus scalability. And I think ultimately where I see this is developing kind of stepped care approaches so that you can reach broad, applying this at the system level, let's say in a healthcare system, right? Identifying where are my high need patients, giving those maybe the more intensive one-on-one type care. And then the people that are maybe at risk, but not quite there, you can give them a lower intensity intervention while tracking them, and then you can move them into the different buckets, right? That's kind of where I see this generally going, and that speaks to both personal level personalization and kind of diagnostic level or system need level personalization as well.
Okay. That's a fascinating idea, Adrian. But I wonder, in doing that step care component, because you're getting a lot of data back, part of the studies, if I understand you correctly, you're doing sort of machine learning. So the computer's making those decisions of what to send, how to send them, stuff like that. But are you thinking of also involving clinical judgment in getting this data and making those adjustments as it go away, or a combination of those things?
Yeah. I mean, I think right now we're testing out different components, right? So we haven't put it all together, but I think some of these, hopefully these things will be in service of that ultimate goal. And I think that, one of the ways I see, for example, the physical activity intervention is we want to improve. So even though you're just getting messaging, you want to make that as good as possible, right? And so you could do this, let's say a texting intervention. But then you might add, for some people, it just might not be having an effect, either in terms of their physical activity, or they may just stop kind of engaging. And then for those people, then they may need something else. They may need someone to check in with them and say, hey, what's going on? Let's work through some barriers maybe, right? And that person could be like a peer, to work with them. And then you can kind of run that and see how those folks are doing. And then if they're still not responding, then that's when you maybe scale it up to say, okay, now we need a clinician, a professional, right? Somebody who has more expertise to address kind of some of these issues. And so I think that if we take that type of approach, at least, we could then hopefully have better outcomes as a whole, so that resources are used most effectively.
I see. So we may have a chance for one more question before we run out of time.
So this might not be a 1.5-minute question, but I guess I'm curious from a professional development standpoint, sort of how you got into this, what types of partnerships you've had to make, and if I'm a doctoral student or a postdoc right now, what kind of sort of training environments or training institutes, anything that you would recommend for people to pursue this kind of work, which I'm sure has a number of challenges?
It's a great question. It's fun to think back on. I think, so I started this in 2009, 2010, when things were kind of just starting to get big, when there was a lot of hype. I think there are a lot of training programs. So there's the NIH has an mHealth training program, which I think they might still be doing. It was kind of a summer program, and it's been on and off. I don't think they've done it due to the pandemic recently. but so NIH is doing a lot more in this area. I think one thing I will caution people against, even though I did it because I had to do it, I don't encourage people to build your own software necessarily. And I didn't do it. I partnered with a software developer and I kind of ended up designing it. But that's mostly because what I wanted to do wasn't available at the time. But now there's more available. So use tools that are out there. And then if for whatever reason the tool that's out there doesn't meet your needs, then potentially explore the building of things. And then I think lastly, there are a lot of private companies out there, and there's also some benefit to potentially partnering with them. The problem is often that their goals are often not aligned with the goals of, let's say, a doctoral student or an academic in terms of doing science. They want to do what's good for their bottom line, right? So being very clear around what are our goals, and if you share data, for example, can I publish based on what the data says, or are you going to have limitations around that, right? So these are kind of a lot of different factors. And then I just say the last thing is play with people that are different than you in different disciplines, folks from computer science and information science and just kind of other areas. There are people in those fields that are interested in similar problems. I think when you bring together their perspective, their skill with our perspective, where we sometimes have more of a sense of what reality is on the ground, then I think more interesting things can happen.
That's really helpful. Thank you.
Super helpful. So we're at the top of the hour. Dr. Aguilera, thank you so much for a stimulating presentation and great work. We will send you the recording when we have it. Thank you everyone for participating. And we will be back in the fall with our new seminar series starting in September. So thank you so much.
Take care all. Thank you.
Have a great summer.
Aaron, you mind staying 2 seconds?
Yep.
Of the recording. Yeah. No.
Did you
Adrian,
say bye?
muchas gracias.
Okay, bye.
All right. Gracias por todo. Can you stop the recording? Yeah.